FSCAI Conversations in Interventional Cardiology. My name is Andy Goldsweig. I'm Director of Cardiovascular Clinical Research at Bay State Medical Center in Springfield, Massachusetts, and Associate Editor of JSCAI, the Journal of the Society for Cardiovascular Angiography and Interventions. I'm honored to represent JSCAI and our Editor-in-Chief, Dr. Alexandra Lansky. You can find us online at jscai.org, that's JSCAI.org, on X and Blue Sky at MyJSCAI, on YouTube at SCAI-TV, on ViewMedi at JSCAI Journal, and on Spotify and Apple Podcasts at JSCAI Beats. JSCAI is home to all official SCAI documents. We're here today to discuss an important recent publication, JSCAI, entitled Variability in State-Level Regulations Regarding Occupational Radiation Exposure. We have an esteemed panel of internationally renowned experts who will join us today and tell us about this research. The first author, Dr. Amit Vora, an interventional cardiologist and director of the transcatheter mitral valve program at Yale New Haven Hospital in New Haven, Connecticut. The senior author, Dr. Sunil Rao, an interventional cardiologist and director of interventional cardiology at NYU Langone Health Systems in New York, and also past president of SCAI. And Dr. Michele D, an interventional cardiologist at Northside Hospital Cardiovascular Institute in Atlanta, Georgia, and co-chair of the SCAI Women and Innovations Committee. So, ladies and gentlemen, thank you so much for joining.
Thank you.
Thanks very much, Andy.
Yeah, thanks for having us.
Our first question will go to you, Dr. Vora. In this paper, you and your colleagues looked at occupational radiation regulations in all 50 US states. You found some common ground, but also some striking differences in state requirements. Can you summarize your group's finding for our listeners? I know that you prepared some slides.
Yeah, absolutely. Thanks very much, Andy, for having me on. It's a pleasure, and it's great to talk about this project that we had worked on in collaboration with many of our other SCAI colleagues. So by way of background, as you know, interventional cardiologists have one of the highest rates of occupational exposure to ionizing radiation, which has been associated with higher rates of malignancy, cataracts, vascular neurocognitive aging, and a wide variety of other sort of health concerns. And right now, next generation enhanced radiation protection devices, I think, can potentially significantly reduce occupational exposure. But with in order to have broad adoption of these technologies, we need to ensure compliance with the appropriate regulations. And so in the United States, there's a multi-tiered and overlapping system of regulatory authorities that govern exposure in the workplace. And so at the federal level, the Food and Drug Administration regulates the manufacture of X-ray systems through the Electronic Product Registration Control provision of the Federal Food, Drug, and Cosmetic Act. Whereas the Occupational Health and Safety Administration regulates occupational radiation exposure and mandates disclosure of this exposure to employees. The NRC, the Nuclear Regulatory Commission, really establishes the overall guidelines for dose limits and works in partnership with state regulatory authorities. But while all of this is occurring at the federal level, at the state level, there are 50 different agencies that are in charge of regulation with respect to radiation. And so the objective of this project was to identify details regarding state-level radiation regulations, to evaluate the differences, especially with respect to barrier protection requirements, and then finally to create a centralized resource with which to disseminate this information. We reviewed state regulations to determine the specific regulatory body in that state that's responsible, the overall annual occupational dose limit, specific shielding requirements, dose monitoring requirements, whether there's specific training or certification necessary to operate this equipment, site-specific radiation safety programs, and then also whether there are what the enforcement actions are in the setting of non-compliance. And so overall, you can see that there's some variability in state-level regulation. In terms of which department is responsible for the regulation, the Department of Public Health is responsible in the majority of states, but there are a number of states where it's the Department of Environmental Protection that really focuses on this regulation. All states adhere to the NRC standard of 5,000 millirem or 50 millisieverts annual exposure limit. But it is important to know that the international consensus by ICRP recommends 20 millisieverts, although this has not been widely adopted in the United States. Most states require a single dosimeter on the body. Also, the majority of states have specified training and/or certification requirements, as well as site-specific radiation safety programs. The URL here really has consolidated all of this information for easy accessibility. The biggest variation, however, really is in barrier regulations nationwide. And you can see that the specific language that's codified is variable across states. There are some states that require only 0.25 millimeter lead equivalent general protection. Others have specific requirements for apron, anywhere from 0.25 to 0.5. Others sort of have differences for apron in general, etc. And so we created this map really to highlight some of these differences. And this is also available in the manuscript as well. And so why does this all matter? Well, for one, operators and healthcare systems sometimes span multiple states and localities. And so it's important to ensure compliance across what is a patchwork system. For example, when states or when institutions are introducing ERPDs, they need to ensure that the new systems comply with the existing regulations in potentially multiple states. And they may need to seek specific exemptions to conform with these state regulations. Finally, the options for changing these regulations also are variable. Some states have administrative rule setting authority, whereas others may require legislation to change these regulations. And so in conclusion, broadly speaking, many of the regulations are concordant across states with respect to annual dose limit, personnel dose monitoring, specific training or radiation programs. But there are substantial differences, particularly with respect to barrier protection. And so greater homogeneity in regulatory requirements really may facilitate broader adoption of this next generation ERPDs. I would like to highlight our contributors for this manuscript. This was a project that initially was conceived by Dr. Rao, but then we were able to secure a lot of help from many of the ELM participants, the Emerging Leadership and Mentorship Program. And so it really was a group effort to collect and centralize these data for broader use. Thanks very much.
Fantastic. Well, Amit, thank you very much. That's a really comprehensive survey of what the radiation regulations are throughout the country. And this is really important work, I think, not just for interventional cardiologists, but for interventional physicians of all flavors who are exposed to radiation and who are exposed to orthopedic risks from their radiation protection equipment. So this makes a big difference. Recently, SCAI, particularly led by Jim Hermiller, has been working very hard in the radiation protection arena. So this is a super valuable resource. Question for you, Dr. Voeltz. In addition to having a busy interventional cardiology practice, we know that you lead the SCAI Women Innovations Committee, and we know that radiation risks, especially as they relate to pregnancy, are a major contributor to the shocking paucity of women in the field. I think the statistics show that still less than 5% of interventional cardiologists are female. So I wonder if you could comment, what's lacking in these state regulations? How do these regulations still leave interventional cardiologists at risk? What do the states and the feds still need to do?
Well, so first, I think it's important when we address pregnancy, once again, the European guidelines are significantly lower than the American guidelines. So the radiation dose limit for pregnancy is 10 times less in Europe than it is in America. And I think that's very significant. I think many of us as interventional cardiologists get very irritated by dosimeters and, having to sort of be told what our limits are and when we've reached them. But in truth, we have to protect ourselves. The damage from radiation is invisible. And we don't know until it's too late that we have been exposed to far too much radiation. I think that, like many things here in America, there are too many hands in the pot, and we don't really have a good, strong idea of the right thing to do. I think if we follow the European model, where there's a single governing body that gives us our radiation dose limits, then it becomes much easier for us to band together and get the appropriate protection. Unfortunately, when we have all of these different numbers, it's very hard to turn it around and bring it to the hospital and say, these are the things that we need. Because if the state numbers are different and we don't have a single governing body, then we don't really have a leg to stand on when we request more aggressive radiation protection.
A great point. The diversity in state regulations sort of makes things look disorganized, right? We're not a unified body with a unified standard, and we can't wave that in front of the people who have the power to ultimately fund that radiation protection and enforce it. I want to turn to Dr. Rao for a second. We've just heard from Dr. Voeltz that state regulations provide a very variable patchwork of protection from occupational radiation exposure. So then the hard question is, what can we do to improve it? Specifically, you're a former president of SCAI. How can SCAI, as the Interventional Cardiology Professional Society, the professional home for interventional cardiologists, how can SCAI lead the change that's necessary here?
Yeah, thanks, Andy. And first of all, I want to congratulate Amit on really doing a fantastic job with this paper. It wasn't easy, and getting these data into press, I think, are the first step in trying to increase the advocacy for protecting our interventional cardiology colleagues. And as you mentioned, this really spans all professions that require radiation protection. It's not just interventional cardiologists. But I think SCAI, really representing interventional cardiology, has a lot of plans sort of to try and address these issues. And this is really just forms the foundation. I think by establishing that there is variability in the barrier protection regulations, SCAI can then formulate a plan to try and address this. And they're doing that already just by raising awareness, number one. And I think that there's a very, very strong advocacy arm of SCAI that deals with governmental regulations and with governmental bodies that I think is going to be really kicked into high gear to try and, sort of either unify regulations or help the interpretation of those regulations to facilitate the installation of some of these advanced radiation protection barriers. I think that it's becoming pretty clear that not only is it a radiation protection issue, but it's also an orthopedic issue. And it's been termed an occupational hazard, and I think that's probably the appropriate way to look at it. And that occupational hazard really does need to be dealt with. We know that there are protections that are available. So when you start thinking about as low as reasonably achievable, I think that goes beyond what maybe we talked about when you and I were in training. I think it really should start encompassing some of these more robust radiation protection devices so that people can either wear very, very light lead or potentially go lead-free if the amount of protection is sufficient.
Forever, really, there has been kind of this trade-off in terms of having stringent requirements for aprons, for lead aprons, for example, where there's this trade-off between sort of protecting against orthopedic injury and protecting against radiation. The hope is that with these ERPDs, that trade-off is now obviated. And so in that setting, I think having kind of more homogeneity in terms of these requirements really can potentially help facilitate broader use.
Yeah, I totally agree. I think that for too long, we've been trying to balance those two things. And there are solutions now that don't require that balance anymore. And I think SCAI really has been the sharp end of the spear here in trying to get these regulations moved and trying to convince health systems that it's worth protecting their interventional cardiologists.
And also, really, the responsibility for radiation protection has been put onto the physician traditionally, right? You want to be more protected, wear more lead. And that's unfair and unacceptable. We should be protected by the hospitals and the institutions who employ us. It's not onto us. When a woman becomes pregnant, she shouldn't have to wear 2 or 3 leads and let her back suffer. We really need to push the hospitals to take care of us and to take that responsibility partially off of our shoulders.
The term "as low as reasonably achievable," the Lara principle, is really a double-edged sword. On one edge, it sets a target which can continually decrease. Now that technology is advanced, lower is achievable. As technology continues to advance, even lower will be achievable, which is great. On the other hand, it's not an enforceable or numerical standard. It's not like saying 20 millirems, 0.5 millimeters lead equivalency. As low as reasonably achievable, well, as low as your hospital administration thinks they can reasonably achieve according to their standards, right? So it seems like perhaps some hard numbers may be in order, and numbers that change over time as what's reasonably achievable changes over time.
Yeah, I mean, I think that, so the NRC sets the overall limit for exposure. I think in a federalist system, states do have the opportunity to set lower. No one really has as of yet. And so I think it'll be interesting to see as things move forward, whether or not there will be sort of more stringent regulation driven by the fact that the technology has improved significantly.
Lots of work left to do in the field of radiation protection, but this paper is certainly a huge step in the right direction in terms of protecting all members of the field of interventional cardiology and interventional physicians. So we're thrilled to publish this important paper in JSCAI and to share this discussion with this incredible panel. To our listeners, please follow JSCAI. Please submit your own work to JSCAI. JSCAI is the official journal of the Society for Cardiovascular Angiography and Intervention. So online at jsky.org, on X and Blue Sky at myjsky, on YouTube at SCAI-TV, on ViewMedi at JSCAI Journal, on Spotify and Apple Podcasts at JSCAI Beats. Thank you all very much.